Hi, we are entering the month of November now, and the theme is Movember. It's all about men's health awareness. So I'm Dr. Dorai Ramanathan, Consultant Medical Oncologist in Zahra Hospital. I'm joined by Dr. Hassan Ghazal, my colleague, Consultant Medical Oncologist. Dr. Ghazal, welcome to the podcast.
Thank you. Thank you very much.
Dr. Ghazal, before we proceed, just, do you want to introduce yourself more, your experience in the field of oncology?
So I'm Hassan Ghazal. I'm a consultant in medical oncology and hematology. I spent about 29 years in USA for my training, and then I worked there for so many years, different states. But anyway, I decided to come back to our region, and I've been in UAE for 5 years at Zahra Hospital currently for the last 7 months or so. I'm glad we found a good team here at Zahra with all my colleagues. So far, certainly a very rewarding experience.
No, we are glad that you joined us, and we want to make a difference. That's why we are here. So we are moving on from the month of October, where there is a lot of light shown on the month of October. We're talking about women's health, breast cancer awareness. This is November. What does it mean to the men's health awareness?
Certainly. First of all, I'm glad they did something for men, because we have been hearing about breast cancer, obviously, for many, many years, and always October pink, everybody wearing pink, and so much publicity about breast cancer, which is certainly deservedly so, but not to ignore men.
Correct.
Men get as sick as women. Actually, their survival stage 4 stage is always a little worse than women. So I'm glad we have, right after October, November is the male malignant month awareness, basically, because, many men are not aware what kind of cancer is very high in men, and what kind of precaution we need to take, and screening methods, because as any cancer, when you detect cancer early, the cure rate is very high. Rather than ignore what your body has been telling you until, unfortunately, we don't want to see patient coming with advanced stage cancer.
Yeah, and we will agree for sure that is as bad in terms of the frequency, incidence, and prevalence when compared to the breast cancer. Probably prostate cancer is the most prevalent cancer in the entire world, and and we tend to ignore it until it's late. I also think that men find it tough. They think they act tough. They don't want to show that they have a problem. They are feeling embraced about this, and that too, when it's specifically talking about prostate or testicle or bladder, it's talking about sexual health and urinary symptoms, and they don't want to talk about it. But I agree with you that it's so important that they think and talk about it, because we all agree early detection, early prevention can cure these people. What would be your message to men at this point in terms of approaching a specialist, in terms of screening, whatever? Let's talk about prostate specifically at this point. What would be your message?
Sure. So prostate cancer, as you mentioned, is one of the most common cancer. It's still number 1 in men. And that's because 1 in 7 men in their lifetime can have prostate cancer. In fact, we have always read about data. If you do cadaver biopsies in people 80 or above, half of them may actually have microscopic carcinoma in their prostate. So it is a common finding, unfortunately. The prostate is a little bit unique because as we age, as we go over age 45, 50, naturally the prostate gets enlarged. So many people start to mix up symptoms of an enlarged prostate, which can be what we call benign prostatic hyperplasia or BPH. And that has nothing to do with the cancer. It's a really different zone in the prostate that enlarged. And a cancer type, which is usually the more scary one, obviously. And both can present with urinary symptoms.
Correct.
So when men start to say, okay, I'm getting 2-3 times a night to urinate, that's a sign of an enlarged prostate. Most probably is benign, but also cancer can give you similar symptoms.
So if I have to say, do they have to take it seriously with those urinary symptoms? Can we reassure them, or is there a way they approach and get this sorted? I mean, how relevant is PSA for screening?
So screening history in prostate cancer goes back to really years ago, 3-4 decades, when the PSA was introduced. We have been ups and down with PSA. So many guidelines initially recommended men over age 50 to get annual PSA screening as well as digital rectal exam to check on the size of the prostate. Unfortunately, through the years, especially in the USA task force, which is the one that kind of look at the data and decide economically if this is good for the country as a whole population or not for screening. And they recommended like 15 years ago against it because they didn't think it's going to be economical. Not only economical, it created some tension unnecessarily because not every high PSA is cancer, as you know. So when you have BPH, when you have urinary infection, PSA can go up, not from cancer, from other condition. So when you do screening, it's very important you follow with a urologist or a medical oncologist or your family doctor to really check, is that high PSA from something malignant or benign? And that's where was the dilemma of accepting screening. But look what happened. Over 10 years in the US, they noticed that the advanced stage prostate cancer went up. And therefore, the mortality, the death rate from prostate cancer went up when they did not recommend PSA screening. So they went back 10 years later and changed the recommendation. Now they are saying, no, it's better to do PSA screening as long as you follow the test with a specialist to see if really this needs biopsy or
to avoid the confusion that can happen. I mean, we know it's a prostate-specific antigen, so it is specific to the prostate, but we are not saying it's all related to the cancer, which is what you're also emphasizing here. But your one-line message would be about PSA and screening. What would that be?
So I would definitely say PSA screening saves lives. So please, if you are over age 50 or even 45 with urinary symptoms, do your PSA screening and follow it with somebody who knows about the subject. Because that was the problem, that the lack of recommendation was stemming from not every high PSA is specific to prostate cancer. But it goes up with age. That's another point. So if I'm 45 and my PSA is 4, even though you read normal level 0 to 4, a 4 in a 45-year-old is actually like 10 in a 75-year-old. So you have to know all the ramification of a PSA. But the bottom line, yes, do the screening because it does save life and it will limit detection of advanced stage, which causes the death of patients.
Perfect. I mean, like we just spoke about breast cancer before. We talked about the genetic link of the breast cancer, BRCA1, BRCA2. We all know that these are very BR is a breast cancer. That's why the name is BRCA gene. But we also know that these same BRCA genes are linked with the prostate cancer. So what would you say to people with a strong family history of not prostate cancer, but maybe breast cancer? What should the men do in that family?
You are absolutely right. So when we say BRCA or breast cancer gene, which was discovered again about 25 years, 30 years ago, it was linked to breast cancer. But slowly we get to realize that really no organ is immune when you have BRCA alteration, especially prostate. So in fact, if you do testing for BRCA or BRCA-like gene changes,
the HRR,
up to 28% of prostate cancer patients may harbor something called HRR, which means repair deficiency. So there is something wrong in the repair mechanism, which is what BRCA really alteration is, as high as breast cancer actually. So yes, it's called BRCA gene, breast cancer gene, but it's just as high as breast cancer gene in a breast cancer woman.
So I think it's a strong recommendation for everybody who had a very strong family history of breast cancer to even consider prostate cancer. The male members should consider, of course, screening for the breast cancer also, which is a possibility, but then for prostate cancer, we agree on that.
And other organs, just to complete the subject, ovarian, pancreas, all these can have
with the same gene.
Can be related to the BRCA.
So sticking to prostate cancer in this podcast, I just want to ask a subtle question to say, people talk about cycling and prostate cancer. You know, people would love to keep themselves fit and take the cycling as a hobby, as a regular exercise. What is your take on this?
Well, there is nothing wrong with exercise. In fact, we encourage staying healthy by increasing exercise. Exercise actually keep our immune system healthy. So to fight cancer changes, you need a healthy immune system. So this is a link between, if you want, exercise.
Preventing
and
cancer.
Exactly, and keeping your immune system healthy to prevent any generation of these cancer changes.
I mean, to add on to the reason that I was also addressing the question is that, historically and many patients, and, there are some evidence to say people who are professional cycling, maybe the way they dress up, and whatever, they seem to think that the prostate cancer has an occurrence. I don't believe there's a strong evidence supporting that. I do not even know whether I should call it as a myth yet, because maybe there's some link, maybe not, but certainly it's not something
true,
you have to
no.
stop. You're not going to stop cycling to sort of think about. So this is something for you guys to understand, that exercise is still the best thing that you could do to prevent things.
Absolutely.
Okay,
and obesity, just to complete, obesity is second to smoking in terms of cancer risk. We're always thinking smoking is bad. But actually, obesity is coming right after smoking now as a reason for cancer, including prostate cancer.
We have 13, 15 cancers linked to obesity directly, like you said, actually. Focusing a little bit on the oncology side of prostate cancer, once a diagnosis is made, we talk about surgery, we talk about radiotherapy, and how important is wait and watch or surveillance. And again, briefly, how would you reassure the patients that you don't need treatment always?
So exactly right. So just like if anybody knows about the cervical cancer changes, where we have early cancer or pre-cancer, and then the invasive part, and the invasive can be different stages, same as prostate. So you could have a low-grade prostate cancer, which rightly so, when you said, we can do surveillance, meaning we don't have to jump and do surgery. As you mentioned, in men, we are afraid of surgery. We think our private life and sexual health will be different. Continence of urine will be different, etc., which is true to a certain extent, but when we need it, we need it. So not every prostate cancer need immediate therapy. Surveillance, we offer surveillance certainly to patients who we think are candidate for it. So not somebody who comes and see you once every 2-3 years and they keep traveling and they are not compliant. So you need good compliance. You need follow-up with a specialist, again, that know what they are doing. PSA screen, follow-up, serial PSA test is important. And even I would go to either serial biopsies could be needed at times.
Keep it to the surveillance program as per the standard. And I think the patient compliance is very important if you decided to wait and watch. It's, as much as recommendation, it's whether you are compliant with the whole recommendation is very important. How scary is for somebody to go through a prostate surgery? I mean, of course, a urologist would answer the question better, but in your 20 plus years of experience, how easy or difficult it is?
So I tell you, in the old days, it was a difficult surgery because take 8-9 hours sometimes, and it's a major operation in the pelvic area with all kind of complications. The story started changing initially with the laparoscopic approach, which means you do the surgery with really small holes. And then robotic really changed the whole field. Why? Because robotic give you a more wider view and a better view of all the natural organs and tissues. Why important? Because of the nerves.
Correct.
If you sacrifice the nerves in those areas, that's when you get impotence, urinary incontinence, all kind of problems. And that's where robotic surgery should be the way to go. So don't do surgery with any surgeon who does once a year operation.
Correct.
This needs to be done in the hands of a surgeon that does this on a weekly basis.
We are very happy that in Zahra Hospital we have excellent urologists, uro-oncologists specifically, and some of them are trained in robotic prostatectomy and robotic surgeries. And I take your point to say you need to be doing it with people who know what to do. And of course, we always talk about the multidisciplinary team approach. I think the decision should always be made by a team who's dealing with these sort of situations all the time. So that's great. So just to highlight, prostate surgery with robotic, the risk of impotence and the incontinence is much better, so people don't have to be scared about going ahead. Again, radiotherapy briefly.
So obviously, if somebody has comorbidities or over age 70, 75, these type of operation are not easy to do, and that's why sometimes we put an age limit or age plus comorbidities. Are you a candidate for this or that? So if absolutely no way you can do surgery, then obviously radiation is the next best option.
Correct.
And I'll say one thing, radiation data actually is as good as surgery in a
certain group
as a third party looking. Sometimes surgeons say, no, our numbers are better. When we say that, you look at the recurrence at 5 years and at 10 years. Again, we measure this in years because sometimes it takes that long to show recurrence. But PSA is a good predictor of how good your surgery was or your radiation was. But in general, surgery plus perhaps hormonal therapy, a brief time of hormonal therapy, could be 6 months, could be up to 3 years, depending on the risk status, can be really as good, meaning at 5 years, perhaps 60-65% are actually cured of the disease.
True. I mean, with my, we have coming from a radiotherapy background, and then I spoke to all the patients to say there is no head-to-head trial, but it's as good as surgery. So people do not want to wish to go with surgery. Certainly, if the patient is young, we usually say surgery. We get to know the more ideas about the whole disease itself, and then they can always have radiotherapy if by chance something is left behind, something comes back. But it's a non-invasive procedure. Radiotherapy is a non-invasive thing, fairly easy. Nowadays we do hypofractionation, which means lesser number of fraction to treat these patients. There are even more specific therapies like gamma knife and things like that. So radiotherapy is a valid alternative to surgery, depending on the whole situation of the patient and the cancer stage itself. So just to wrap it up, actually, we focused on prostate cancer today, how important is the screening, and what are the roles of surgery and radiotherapy. We talked about the family history, where breast cancer patients, ovarian cancer, pancreatic can also look into the prostate cancer as an option. They should go for screening. You were highlighting the importance of PSA, how PSA is not going to be always cancer, but it's so important. We highlighted about patients' compliance with, keeping in touch with the specialist. So we all say this is not about growing mustache in November. It's about creating the awareness in men's health. Anything to sort of close up the podcast from your end?
No, again, like you said, the message is for men that we do have a month for men now, just like women. Prostate cancer is as common as breast cancer. And if caught early, it's curable in a very high percentage. Rather than, we don't want to see patients coming in with diffuse metastasis already, because we are seeing that's happening, unfortunately. Yeah.
No, thank you. I hope this is an enlightening discussion here. So we would appeal to patients to go approach the specialist, specifically this month, but then throughout the year, really, early detection saves lives. So thank you very much.